بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I'm Nazik Elmalaika, a professor of pathology at the Faculty of Medicine of Durban Islamic University. It's of my pleasure to welcome you in this lesson about aplastic anemia. In this recording, we are going to identify the etiology, epidemiology, and pathophysiology of aplastic anemia, outline appropriate history, physical examination and evaluation of aplastic anemia, and just outline the treatment and management options of aplastic anemia. Aplastic anemia refers to the syndrome of chronic primary hematopoietic failure from injury leading to diminished or absent hematopoietic precursors in the bone marrow and attendant pancytopenia. You have learned in the few last weeks that the hematopoiesis occurs in the bone marrow. The bone marrow is a factory of the blood cellular components, the red cells, the white cells, and the platelets. In aplastic anemia, there is failure of this factory. There is failure of the progenitor cells of the hematopoietic system, with the resultant pancytopenia. Pancytopenia, that is diminished numbers, low numbers of the red blood cells, the white cells, and the platelets. Aplastic anemia can be defined as the presence of pancytopenia in the peripheral blood and the hypocellular marrow in the bone marrow three-fine biopsy, in which normal hematopoietic marrow is replaced by fat. Abnormal cells are not found. This is a mandatory point. No abnormal cells in either the peripheral blood smear nor the bone marrow three-fine biopsy. Epidemiologically, accurate information regarding the incidence of aplastic anemia is generally not available. However, studies suggest the incidence of only 0.6 to 6.1 cases per million population. And this is not the true incidence because this rate is largely based on data from retrospective reviews of death registries. The male to female ratio is approximately 1:1, equal in both genders. Although aplastic anemia occurs in all age groups, a small peak in the incidence is observed in childhood. A second peak is found in the age 20 to 25 years old. There are a lot of bone marrow injuries or settings to injuries of the bone marrow that result in aplastic anemia. The most common etiology is idiopathic, accounting for 65%. A few cases are inherited, for example, Fanconi anemia and dyskeratosis congenita. Fanconi anemia is the most common hereditary cause of aplastic anemia. These are the major causes of aplastic anemia. As you see, idiopathic causes account for most of the cases, about 2/3 of the cases. A small group are due to inherited bone marrow high failure syndromes like Fanconi syndrome, or Fanconi anemia, not Fanconi syndrome, and dyskeratosis congenita. A lot of acquired causes can cause aplastic anemia. Some are chemical agents, some are physical agents, viral or biological infections, and miscellaneous. Within the chemical agents, there are some dose-related and some are idiosyncratic. Dose-related, as you increase the dose, there is a a most probable or high probability to develop aplastic anemia. While in the second category, it is uncertain, or even minor or a small dose of insecticides, for example, or streptomycin can cause aplastic anemia in different patients. Example for the dose-related chemical agents that can cause aplastic anemia: alkylating agents, which are one of the first class of drugs to be used in cancers. They usually cause aplastic anemia. Examples for the physical agents is the whole body irradiation, also used for the treatment of some malignancies, in addition to the accidental cases of irradiation. Biological causes include certain viruses, for example, of hepatitis, cytomegalovirus, Epstein-Barr virus, and herpes varicella zoster virus. Connective tissue diseases, some connective tissue diseases, and even pregnancy can cause aplastic anemia. Fanconi anemia is a rare disorder in the category of inherited bone marrow failure syndromes. It can be associated with birth defects, other birth defects. We will see it soon. It is caused by changes or mutations in certain genes known as Fanconi anemia genes. They are about 23 genes up to date. It leads to gradual bone marrow failure and most often diagnosed in children between 3 and 14 years old. Fanconi anemia presents with pancytopenia, organ hypoplasia, and bone defects, including abnormal radii, the plural of radius, a bone in the forearm, absent thumbs, and short stature. In this figure, you see in figure A that the bone marrow which is hypocellular, and these large cells are the fatty cells. The fatty cells replace the cellular bone marrow. As we said, Fanconi anemia is an inherited disorder. It is caused by a deficit in the Fanconi BRCA, Fanconi BRCA pathway that impacts the Fanconi anemia phenotype. In B, you see abnormal cells instead of the replaced bone marrow with fatty cells. In this case, a new chromosomal aberration occurs. This is AML, acute myeloblastic leukemia, developing on top of aplastic anemia, which is a common acquired chromosomal aberration in aplastic anemia. In C, you see the somatometric features of Fanconi anemia children. They are usually short stature. They may have microencephaly. In D, you see other clinical features. They present with hyperpigmentation, as seen here, or hypopigmentation. The mechanism behind hyperpigmentation is that the café au lait, which is called, these hyperpigmented areas are called café au lait, could be subsequent to acquired chromosomal alterations in skin cells. And in the last figure E, you see the spectrum of thumb of abnormalities or skeletal abnormalities manifesting in thumb. In this hypoplastic condition, there is absent thumbs of the both hands. In the upper one, there is hyperplastic or additional thumb in one of the hands. There are two mechanisms behind the pathophysiology, or two explanations for aplastic anemia. One of them is the extrinsic immune-mediated suppression of hematopoietic stem cells, and the other is intrinsic abnormality of bone marrow progenitors. Damage, in the first case, damaged hematopoietic stem cells mature into self-reactive T cells, or T1, also called T1, that releases cytokines, for example, interferons, whatever it is, gamma, alpha, or other, and tumor necrosis factor, another cytokine, to propagate a cytotoxic cascade to kill and suppress other hematopoietic stem cells, a matter of autoimmunity. There is the damaged hematopoietic that mature into self-reactive T cells, and instead of the body immune system to kill this T helper cell by apoptosis, there is failure in the apoptotic pathway, and this reactive T cell matures and releases cytokines, different cytokines, interferons or tumor necrosis factor, and they established a cytotoxic cascade and start to kill other hematopoietic cells. This is the extrinsic immune-mediated suppression of hematopoietic hypothesis. The other explanation or theory, the stem cells with inherited defects lose the capacity to differentiate and proliferate. Inherited defect like that of the Fanconi anemia BRCA mutation, or that of the dyskeratosis congenita, the telomerase genes. Okay? Their inability to differentiate can lead to clonal evolution into hematopoietic neoplasms. This is a very important point. In some of the aplastic anemia cases, there is a development of a hematopoietic neoplasm. For example, myelodysplastic syndrome, or a myelogenous neoplasm, for example, AML. This is common in patients with Fanconi anemia. Partial defects in telomerase, the component of DNA intertwined with cell division, lead to the premature hematopoietic stem cell exhaustion and marrow aplasia as well. Shortened telomerase are present in cells of half the patients with aplastic anemia. Histopathologically, bone marrow biopsy from patients with aplastic anemia will be markedly hypocellular. Fat cells and fibrotic stroma replace normal bone marrow tissue. Stray lymphocytes and plasma cells remain, and the remainder is devoid of marrow progenitors. Aplastic anemia presents usually at any age with equal distribution among gender and race. Symptoms related to the absent cell lineage. If the red cells are markedly reduced, the patient will present with anemia, pallor, progressive weakness, shortness of breath, dyspnea, and the symptoms of anemia, other symptoms of anemia. If the neutrophils are markedly low, the patient will present with frequent and persistent infections or sudden onset febrile illness that can lead to death and considered an emergency. If the platelets are very low, the patient will present with subcutaneous bleedings manifested as ecchymosis, mucosal bleeding, and petechiae. Characteristically, splenomegaly is not seen, and its presence suggests an alternative diagnosis. Labs will demonstrate normocytic normochromic anemia with reticulocytes, neutropenia, and thrombocytopenia. There must be no cytologic abnormalities, as this would suggest an underlying hematologic process. The diagnostic criteria for aplastic anemia are as the following. There should be presence of bone marrow hypocellularity in the bone marrow biopsy, plus 2 or more cytopenias, either reticulobudia, that is the reticulocytes less than 1% or less than 40,000 per microliter, or neutropenia, less than 500 neutrophils per microliter, or thrombocytopenia, platelets less than 20,000 per microliter. Aplastic anemia is divided into moderate, severe, and very severe aplastic anemia. The moderate disease has less than 30% bone marrow cellularity, and the severe disease has less than 25 cellularity or less than 50 cellularity containing fewer than 30 hematopoietic cells. And the very severe meets the severe criteria plus neutropenia less than 200 per microliter. This is another expression of severe aplastic anemia, in which the bone marrow cellularity is less than 25% combined with 2 of the following abnormal laboratory abnormalities: acute absolute neutrophil count that less than 0.5 times 10 to the power 9 per liter, or platelet count less than 20 times 10 to the power 9 per liter, or reticulocyte count less than 1%. Aspiration of the bone marrow has little yield. You know, there are two procedures. One is bone marrow aspiration, and the other one is bone marrow biopsy. The bone marrow, the needle of each one is different. The needle of the bone marrow aspiration is narrow. That of the bone marrow biopsy is wider. You take cells in the bone marrow aspirate and smear them and stain them with right stain or Giemsa stain, while the biopsy is a tissue that should be fixed in formalin and processed in histopathology lab and seen under microscopy after staining with hematoxylin and eosin. The aspirate, the bone marrow aspirate, is not useful because you usually it is usually dry tab. While the bone marrow biopsy is essential, it will be markedly hypocellular and devoid of marrow progenitors. Genetic testing, other ancillary tests, for example, genetic testing with flow cytometry and fluorescence in situ hybridization, is useful to exclude hematologic malignancies responsible for pancytopenia. Additional testing depends on the underlying condition responsible for bone marrow failure, for example, telomerase mutation testing for dyskeratosis congenita. This photo shows a normal bone marrow aspiration at medium magnification. The white globules are the fatty cells, and those cells in the background are the cellular component of the different progenitor cells. The large ones are platelets, and the other dark nuclei are the red cell progenitors, and those with a lighter cytoplasm are the white cell progenitors. The normal bone marrow shows usually 50-50 combination of 50% cellular component and 50% fatty component. This is the close-up or a higher magnification of the bone marrow. These are the fatty cells, and this is the cellular component with megakaryocytes, the large cells. These are the precursors of the hematopoietic red blood cells, and these are the precursors of white cells. The bone marrow biopsy, which is stained with a tissue fixed in formalin and stained with hematoxylin and eosin. This is the pinkish color, hematoxylin and eosin, the background. These are the stains for this microscopic picture. This bone marrow biopsy also shows the 50-50 components of the red cells and the cellular component. Okay, and this is the hypocellular bone marrow trafine. Most of the cells are the empty cells, the fatty cells. There are only a few remaining hematopoietic cells. These large pinkish areas are the bone marrow trabeculae. This is an aplastic marrow of a true real case. The large component here is the bone marrow trabeculae, woven bone, and the marrow area, which is the factory of the hematopoietic cell, is replaced by fatty cells in more than 50%. Only a few areas with cellular hematopoietic cells remain. This is a close correlation or comparison between the normal bone marrow trafine biopsy, in which the cellularity is 50-50, and the lower one is of a bone marrow trafine of aplastic anemia. The differential diagnosis of aplastic anemia is the all causes of pancytopenia, which can occur due to myelocystic syndrome, which is a pathologic process that replaces normal bone marrow. Etiologies of this myelocystic syndrome are solid tumors, metastases, for example, tumors of the lung, CA breast, CA prostate. Most of the solid, or these are the common solid tumors that metastasize predominantly to the bone marrow. Other tumors, hematopoietic tumors, lymphoma, and myeloid neoplasms, for example, multiple myeloma. For example, acute myelogenous leukemia, also leukemia, AML, can be diagnosed from or seen in the bone marrow trafine biopsy. Myelofibrosis, in which the bone marrow is replaced by fibrous tissue. Hemophagocytic lymphocytosis, in which you find a lot of histiocytes and large cells engulfing hematopoietic cells. Osteopetrosis or Gaucher disease, which is an historic disease. The bone marrow biopsy will not be hypercellular in these conditions, and it reflects the underlying disease. The differential diagnosis, as we said, is one of them is a leukemia. For example, acute lymphoblastic leukemia. And this bone marrow shows how cellular is the bone marrow trafine biopsy in a child with ALL. This is the cellular component predominates, no fatty cells here. Hypercellular marrow is seen in leukemias, whether acute or chronic. The differential diagnosis also includes myelodysplastic syndromes, in which the bone marrow is not hypercellular. It contains cellular components but are atypical. They are abnormal precursors of the hematopoietic cells. This megakaryocyte, the large cell, the progenitor of the platelet, containing only 2 nuclei. This red cell progenitor is large with excentric cytoplasm, and this white cell progenitor is abnormal also. The bone marrow biopsy also shows the atypical, the abnormal hematopoietic cells. This is a megakaryocyte, the precursor of the platelets. This is an abnormal progenitor cell of the red cell component. The differential diagnosis also include paroxysmal nocturnal hemoglobinopathy or hemoglobinuria and acute lymphoblastic leukemia, as we said, and hairy cell leukemia. Other causes of pancytopenia should be excluded, and they include hypersplenism, megaloblastic anemia due to B12 or folate deficiency, myelodysplastic syndrome, immunocytopenias, hemophagocytic syndromes, paroxysmal nocturnal hemoglobinuria. Infections are very common causes of pancytopenia in Sudan. Brucellosis, leishmaniasis, malaria, disseminated tuberculosis are all common causes of pancytopenia in Sudan and should be ruled out before the diagnosis of aplastic anemia. Also, overwhelming sepsis can cause pancytopenia. The management of aplastic anemia is directed at the underlying cause. Remove the offending agent if possible. As we said, there are many chemical agents that can cause aplastic anemia. Therefore, some drugs have been discontinued in the United States due to their associations with aplastic anemia. Briefly, the management of severe aplastic anemia is mainly supportive care for the bone marrow failure or specific therapy. The supportive care guard against the anemia, the diminished or reduced count of red blood cells, and against thrombocytopenia, the low count of platelets that cause bleeding, and the low number of white blood cells, neutropenia, the cells that defend the organisms, the foreign organisms from our body. For anemia, you give back the red cells or erythropoietin, the hormone that increases the progenitor cells, the hematopoietic, erythropoietic progenitor cells to produce red blood cells. For thrombocytopenia, you give platelet transfusion and thrombopoietin, a similar synthetic hormone like erythropoietin, to increase thrombopoietin, to increase the production of platelets. Neutropenia, in this case, it would be better to isolate the patient to guard against acquiring other infections. You give antimicrobials, wide spectrum. You can give granulocyte colony stimulating factor or monocyte colony stimulating factor to activate the genesis of the white cell precursors, or granulocyte transfusion is another option. The supportive care is very important, and it includes oral hygiene, general hygiene, nutritional therapy, as well as psychosocial support. On the other hand, specific therapy was also used. There have been, or androgens and splenectomy was used for a long time for as a specific therapy for aplastic anemia, but nowadays they are obsolete. They are no more used. Instead, immunosuppressive therapies are used currently, and they are different, or two courses. One is moderate and the other is strong. The moderate intensity prolonged course includes prednisolone, cyclosporine A, and cyclophosphamide. Worldwide in the developed world, there is a combined new therapy which is named or called Eltrombobag is used currently for aplastic anemia. The other course is a strong intensity short course in which anti-thymocyte globulin is given. This immunosuppressive drug or therapy for aplastic anemia is associated with high morbidity and mortality. The other specific therapy is the allo bone marrow transplantation, which is called allogenic hematopoietic cell transplant. It's usually offered to young patients less than 50 years who are healthy, otherwise healthy, and who have HeLa matched donor, HeLa human leukocyte antigen matched donor, and the cure rate in this entity is promising. It is up to 75% when they are identical twins, or the donor is the identical twin. Survival in aplastic anemia depends largely on age, disease severity, and the response to the initial therapy. Those who recover following drug cessation or treatment of underlying condition have stable clinical courses, as well as those with self-limited processes, as in during pregnancy. And the 5-year survival is about 75% for patients who undergo bone marrow transplant from a suitable donor. The majority of untreated patients die within 1 year from disease-related complications. And these complications include bleeding, infections, or transformation to lymphoproliferative disorders. The most common causes of this are infections and bleeding. And these are managed by surveillance, frequent check, regular checks or investigations, and symptomatic treatment including antibiotics, chemotherapy, and/or transfusions. By this, we came to the end of our session today, in which we discussed aplastic anemia, which is a chronic condition with hypoplastic bone marrow and pancytopenia, and importantly, there are no abnormal cells in the bone marrow. Epidemiologically, there are no standard figures, but it is rare generally. The causes are many. The commonest is idiopathic, accounting for 65%. Rare inherited conditions can cause aplastic anemia or associated with aplastic anemia, like Fanconi anemia and dyskeratosis congenita. The more common causes are the acquired, which can be a chemical, physical, or biological agents, and other miscellaneous causes. The diagnosis of aplastic anemia depends on the bone marrow biopsy, which shows hypocellular bone marrow, in addition to 2-cell lineage that are markedly reduced in number. The management is either supportive or specific, and the prognosis depends largely on the age, the severity, and the response to the initial management. By this, we came to the end of our session. I hope that you have a useful or information, and thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.